relationships to disability. Thank you.
Thanks, Rose. Welcome. Thanks for coming. I wanted to thank the hospital for inviting me today. And so the message of today's lecture is that we eat too much carbohydrate. Now, some of you may agree with what I'm going to talk about today. Some of you may disagree, but to be honest, it's all good. The point is that it's a new way to look at nutrition, and I believe that that makes it important. Now, to get here, the hospital actually has to do some critical review of my slides, and Susan Labat, who unfortunately isn't here, I was hoping she would be here, is a registered dietitian, and she critically reviewed my lecture, and she made some excellent comments, and I've actually made some changes and inclusions in the slides that we'll discuss today. So to start, I'd like to just summarize. I'm going to present us with some data, some terminology. Then we'll look at the history of nutrition as it relates to obesity. We'll discuss the science of insulin resistance and inflammation. Then we're going to discuss the management, treatment of patients. We're going to compare diets, which is kind of fun. I'm going to give some patient cases, and we'll summarize with nutrition guidelines. So I have no financial relationships. So we have this twin epidemic that we call diabesity, and this came out from Shape Up America in 2000, and this was Dr. Everett C. Koop. This is his group. And I love that terminology, and basically it states that there's this relationship between weight gain, obesity, insulin resistance, metabolic syndrome, diabetes, and inflammation, and that these are basically two of the same thing that are happening at the same time. And it's a progressive condition. And so we have some statistics, and I get my statistics from the Trust for America's Health. And I update this slide every year, and unfortunately we see the obesity statistics creep up. And they give us an F as in fat, a failing grade. And the statistics from actually 2009 data are that 68% of adults are overweight and obese. 34% of the national data patients are obese. And that's slightly different than the state data, but this is the group that tells us that Colorado is the leanest state at 19.1%. But I tell you, if healthcare professionals were able to deal with those 19.1% of the patients in the state, we'd be quite busy. So it still is a big issue here in Colorado. And when we look at the rates from 1980 to 2008, the obesity rates have doubled. And the child obesity statistics are concerning. We can see the rates have tripled, and now 18% of our children under age 18, I believe, are overweight or obese. So let's look at the statistics of insulin resistance. In the previous slide, I just mentioned that 68% of adults are overweight. Well, I believe that actually represents a statistic also of insulin resistance. 25% pre-diabetic, 39% metabolic syndrome. And we'll talk about metabolic syndrome a little. What's confusing to me is that there's more criteria for metabolic syndrome, one of which is pre-diabetes, and I actually think those statistics should be reversed. But perhaps I'm just the messenger here, and that's the data that I found. 8% is diabetic now, and again, that's creeping up, and I think that's an underestimation. 25% of our population over age 60 are diabetic, and in my office we do a lot of screening, and this is no surprise to me that we have patients over age 65 that come in, and I don't like to do this, but I say, oh, and by the way, you're diabetic. No one ever told me that, doctor. And then there's an estimate that 1 in 3 children born today will be diabetic, so that 8% number will become 33% in 40 years, but not if I can help it. So let's look at the history of nutrition as it relates to obesity. So traditionally, we've thought of obesity as not a medical condition. It's not necessarily related to health. I'm just overweight and I need to do something about it. And it's a personal choice issue. You became overweight because of the lifestyle that you chose to lead. It's your fault. You need to feel guilty about it, and you need to do something about it. And as a result of this thinking, we developed the billion-dollar weight loss industry. And Weight Watchers is a great example that developed in the 1960s. And the science of the time was counting calories, fat is bad, and carbohydrates are okay. But more important is it's designed to pay out of pocket. If you're overweight, it's your problem. So we have government agencies that participate, the U.S. Department of Agriculture and the Health and Human Service Department that come up with nutritional guidelines. And these guidelines really start post-World War II. We have basic food groups, and then a scientist, Ansel Keys, in the 1950s, who was actually born in Colorado Springs, develops the lipid hypothesis. And that hypothesis is that if we eat fat, we get fat, and it's going to lead to cardiovascular disease. Now, there are major flaws in his study. What he originally did was look at several countries around the world, and he threw out the countries that did not fit into his hypothesis. So his hypothesis was, if you eat fat, you're going to get cardiovascular disease. So he threw out countries where they had a high-fat diet, I think in Scandinavia, and a low incidence of heart disease. And he said, well, that didn't fit the data. So he threw it out. It all looked perfect. He got written up in Time magazine, and it was a snowball effect. And he was really the father of low-fat diets. And the one problem that I have also with his work, and every single study that looks at dietary fat consumption, is the assumption is that there's not a problem with the carbohydrates. So sometimes they don't even report the quantity of carbohydrates consumed in the study when they draw the conclusion, and that really is a bad assumption, and it makes the studies invalid. So then we have the government report. Then in 1980, we come up with additional dietary guidelines. It says to decrease fat, increase carbohydrates. As a result of that, we get the food pyramids, which again are carbohydrate heavy. And the fundamental principles at this time are, again, if you eat fat, you'll get fat. And also this idea of the conservation of energy, that if I just eat less and exercise more, I'm going to lose weight. And this theory is based on the physics of a calorie in, a calorie out, if we burn a calorie in a petri dish. And it just assumes that our bodies are petri dishes. But we're missing one point. We are human biologic systems. And it is the way that our hormones react to the foods that we consume that determine what we do with that energy. And so it's not necessarily about this conservation of energy, but it's these two fundamental principles that we've just stuck with for the past 60 years. And again, it was based on the science of the times, but I think we know a lot more. So then we have the healthcare industry where we're at today. And healthcare industry really, the guidelines are set by Medicare and Medicaid. And initially they say that we are here to treat disease only. And since obesity isn't a medical condition, we're not going to deal with it. It's not our problem. That becomes an issue for public health. And of course we know now Medicare and Medicaid have had a lot of pressure to bring in preventive programs. And it's getting better, but it's still a long way off. But the big point is that they set the guidelines for the industry. And those guidelines are that there's no incentive for healthcare professionals to discuss nutrition or obesity with their patients. We're not going to pay for it, so why should we learn about it? And that's exactly what happened to me in medical school. You know, I learned about the ATP cycle, the Krebs cycle, I learned some science, but the actual application, there was nothing. And so I had to go out on my own and learn about it. And surely there's something wrong with that. Okay, so what
is that still the case? There's no coding for you to do counseling about obesity?
It's a great question. So the insurance industry doesn't like to pay for coding related to obesity. And so you have to find, they don't like that code, so you have to find other codes such as cholesterol, insulin resistance, metabolic syndrome. And again, it's silly. There's really something wrong with that. So nutritional guidelines are not working. And some more about that is, it's interesting to note that human diet has been different for 99% of our existence. That's 500,000 or 500 million years. We started out as hunter-gatherers, where we were eating primarily a high-protein, high-fat diet. And what changed in the last 250 years is farming and agriculture, and introduction of inexpensive and unhealthy foods. But I would specifically look at the grain, wheat, and the corn products as the problem food. And so it's hard to change this common sense thinking, and there's all these word bites out there as to what's healthy nutrition, balance, moderation, low fat, low carb, watch your protein. Boy, that sounds like just let's stop eating. So I'm even confused when people throw these terms around. I don't even know what they mean anymore. And let's just say there's social pressure to live unhealthy without going into it too much. And then we have the healthcare industry, which unfortunately is reactive versus proactive. And by that I mean we're spending billions of dollars treating the complications of obesity and not treating the cause, obesity itself and nutrition. And certainly this would be a cost-effective approach. And this is where the term fat reform before health reform comes up, or if you don't like that term, you can say food reform. But the idea is if we want to reform our healthcare system, we have to look at lifestyle first. And that includes reforming the food industry and the information that they're pumping out. So today's challenge, it's very easy to state the challenges on this slide, but it's very hard to make the changes. And so the challenges are to redefine healthy nutrition, to promote wellness and longevity, to prevent and treat disease, and control the cost of healthcare. And the tools that we're going to use are the lessons from the past, and we're going to look to modern science and evidence-based medicine for answers. And the science is that of insulin resistance and inflammation. And so it's like Sherlock Holmes would say if he was alive today, it's elementary, my dear Watson. The problem is with the food. And so it is insulin resistance, which again provides the clues and the answers. Now what's interesting is in insulin metabolism, we've known about it, how it functions, all the details since the 1960s, and how it responds to carbohydrate. But what's new is applying the science of insulin resistance to nutrition. And that's what we're going to do here today. So some of the medical or scientific things that we're going to talk about is, number one, food physiology, and that is how the macronutrients interact with the body, and the macronutrients being the fat, protein, and carbohydrates. And the medical conditions that we like to discuss today are insulin resistance, and it's important to recognize insulin resistance as this progressive condition where weight gain is the first sign. Adipose organ toxicity, inflammation, energy storage disease, we're going to talk about those as well. So we'll talk about insulin in the pancreas. So what does insulin do? In medical school, they taught us that it regulates blood sugar. Yes, that is true. But that's actually a secondary effect. What insulin really does is it regulates energy in the body as we consume. It decides if it wants to burn it. It decides if we want to store that energy. And it is the food that triggers the production of insulin. And the beta cells are in that in the pancreas, and they are most sensitive to dietary carbohydrates. Why? Because it's a simple form of energy. We consider a carbohydrate or glucose the first source of energy. And think about the concept that as we consume carbohydrates, it turns on that insulin switch. Dietary fat and protein are really considered a second source of energy because it has to be processed. And again, this is by human design. Again, we talked about the 500 million years of human existence.